Okay, anti-epileptics or anti-seizures. So, some definitions. Excuse me. A seizure is a brief episode of abnormal electrical activity in nerve cells of the brain. Convulsion is an involuntary contraction of any or all voluntary muscles throughout the body. So think of voluntary, not involuntary. Epilepsy is defined as characterized by a chronic recurrent pattern of seizures. So you have the same type of seizures kind of over and over. Primary is idiopathic. I don't know, right? We don't know why. About half of cases. So secondary is called symptomatic epilepsy. There's a distinct cause. You had a head trauma. You had a cerebral infection. You have some disorder. You may have some mets to your brain, some tumor in your brain, something like that. Okay. So classification. So they change names. We used to have grand mal, petite mal. Now it's generalized onset. Is tonic-clonic and absent seizures. They used to be called grand mal. Partial onset is simple. Used to be petite mal seizures. So there's simple, complex, secondary, generalized, tonic-clonic, and then there's some unclassified. So status epilepticus. Very, very bad deal. Multiple seizures occur with no recovery in between them. So normally you have the pre kind of seizure activity, the actual seizure, and then you have your post-ictal period is where the recovery bit happens, and that's when people are confused or they're sleepy or they're just not quite normal after their seizure. So status epilepticus is when you just have seizure upon seizure upon seizure, and there's no recovery. So hypotension, hypoxia, brain damage, and death. Basically, you fry your nerves because there's no recovering. You can't kind of get that electrical recovery period. It is a very intense medical emergency. Diazepam and lorazepam are the most common given IV during an emergency, right? Your benzos. Be sure seizure precautions are in place. So IV, padded side rails, oxygen, suction, and emergency equipment. You want to time the seizure and patient behavior before, during, and after. Watch the patient's airway, not yours, the patient's, right? Do we ever want to stick something in somebody's mouth who's having a seizure? No. But definitely if they are seizing so much that the sheets in the bed are getting all bunched up around them, that's how we can protect their airway, right? If their gown is getting tight around their neck, we can fix that. So that's what that means. So, goals of therapy. To control or prevent seizures while maintaining a reasonable quality of life, and to minimize the adverse effects and drug-induced toxicity. So this is a balance that is sometimes very difficult to achieve. Meds are usually lifelong. Single drug therapy is started before multi-drug therapy, so we start low, go slow, right? Serum drug concentrations must be measured, so there needs to be amount of drug in your blood to prevent the seizure. If it's low, you could potentially have more seizures. So phenytoin, phenobarbital, carbamazepine, and primidone correlate better with seizure control than valproic acid, ethosuximide, and clonazepam. So valproic acid and clonazepam aren't, when you look at the blood levels, it's not going to be like, oh yeah, your blood levels are normal, you have good control. Not necessarily with those other ones. So barbiturates, we just talked about those. Phenobarb, hydantoins, phenytoin or Dilantin, aminostilbenes plus valproic acid, carbamazepine, second and third generation anti-epileptics, diazepam and lorazepam. Mag sulfate is also used as an anticonvulsant. So, Choice of anti-epileptic drug depends on the patient, comorbidities, type of seizure. So there's variability with all these seizures, right? It's kind of like a spectrum. So you might have super intense seizures. You might not have really bad intense seizures. So it just depends on the needs of the patient. This is very, very patient-centered. Doses are started low and gradually increased until seizure activity stops. If you need to change medications, you withdraw very slow and then add the other drug very slowly. Okay, so overarching goal are to suppress the neuronal activity enough to prevent abnormal or repetitive firing. We want to make it less sensitive to that seizure activity in the brain, but we don't want to block it. We don't want to make you, catatonic and like a vegetable. So, major pharm effects reduces the nerve's ability to be stimulated, right? It kind of numbs it a little bit, makes it more difficult for a nerve to be excited, because what happens in seizures? We've got overexcitability of those nerves, so we need to tone it down. Suppress transmission of impulses from one nerve to the next, so we limit the spread of seizure discharge, right? So we limit how much of the brain that seizure kind of goes. It's like the wave, right? You go to sporting events and you see the wave. Well, we're trying to control the wave. We're trying to not get it to catch on, and then when the wave does catch on, we don't want it to go very far. Decrease the speed of nerve impulse conduction within a neuron. So again, that fast wave, I've seen them. They're pretty cool, actually. Slows influx of calcium and sodium ions across neuronal membranes. Antagonizes the excitatory neurotransmitter glutamate. But it's more stable cell membrane. We have a more stable cell membrane. It's going to take a little more to get it excited and fire. Right? Some enhance the effects of GABA, but most of these drugs have more than one of the above mechanisms. So they do a lot of different things. Okay? No, they work in a lot of different ways. So, anti-epileptic drugs or indications, prevention or control of seizure activity, long-term maintenance therapy for chronic recurring seizures, acute treatment for convulsions, status epilepticus. But there are a lot of other uses. If you guys spent a little time in rehab. When I was a clinical instructor in rehab, a lot of people were on gabapentin or Neurontin. It is an anti-seizure drug. It's an anticonvulsant, but it is used for neuropathic pain. Psychiatric mood disorders, bipolar, migraines, so there's lots of other uses. So just because somebody's on an anti-epileptic drug does not necessarily mean they have epilepsy or they have a seizure disorder. So, numerous adverse effects. They are drug dependent, but they often, if they get so bad, we got to change treatment. So black box warning, suicidal thoughts or behavior, and we've talked about this, how to ask. We just ask, hey, do you have any thoughts of harming yourself or others? Long-term therapy with Dilantin or phenytoin may cause gingival hyperplasia, acne, and hirsutism. So gingival hyperplasia is the overgrowth of your gums. So go ahead. Usually I pull up some images. I can't right now, but Google gingival hyperplasia and then images, and you'll see that overgrowth of the gums. So that's an important thing to assess if somebody has been on Dilantin a long time. One of the focus assessments for that drug is look at their mouth, right? Go slow. We do not want a fast push of this. Numerous drug interactions, most common drowsiness, sedation, GI upset, skin reactions. Right? They're CNS depressant. They depress that nerve activity. Okay, so more anti-epileptic drugs. Valproic acid, it comes in Depakote or Depakote, gabapentin, lamotrigine or Lamictal, levetiracetam, Keppra, Topamax, Lyrica. A lot of these are used for different things. Lyrica is used for fibromyalgia too. So again, that kind of nerve pain thing, right? Neurontin is really used for neuropathies. So, barbiturates, phenobarbital and primidone. Primidone is metabolized to convert to phenobarb. Historically popular anti-epileptic. Most common adverse effect is sedation, and we talked about this. So serum drug levels of 10 to 40 may indicate toxicity, but also nystagmus, confusion, shortness of breath, slurred speech. Again, if your patient is somnolent, we maybe need to check that out. If they can't wake up to talk to you, that's a problem. We like our patients talking, even if they're arguing with us. It's better than them being, having issues with drugs like this, like, respiratory depression and stuff. So contraindications, known drug allergy, porphyria, liver or kidney impairment, respiratory illness. So Dilantin, phentoin, first-line drug for lots of years. Lots of people are on Dilantin. It's prototypical, usually well-tolerated, effective, but that gingival hyperplasia and then the acne and hirsutism and osteoporosis, measles-like rashes, urine discoloration. Those are not side effects. Those are adverse effects. Therapeutic drug levels are 10 to 20. They're highly protein bound. Again, nursing implications. Watch the gums, encourage dental care, and watch for skin reactions, but definitely do a good oral assessment. Right, IV administration. Very irritating. Large gauge catheter, so 20 gauge or larger. Diluted in saline only for infusion, filter, and then you must monitor for extravasation. So what do you think you see with extravasation? So you see redness, irritation, pain, that sort of stuff, okay? Phosphatoin, Cerebex, water-soluble phentoin derivative that can be given IV push or continuous infusion. So it's a little bit of a kind of remade, updated version of phentoin. Okay, carbamazepine, Tegretol, second most commonly prescribed anti-epileptic after Dilantin. Autoinduction of hepatic enzymes, so it enhances its own metabolism, so leading to lower than expected levels of drug concentration. So that's an interesting little thing. Numerous adverse reactions, no grapefruit juice, that metabolic highway. So watch for CBC for aplastic anemia and bone marrow suppression. So yeah, look at that big old grapefruit, right? So gabapentin, Neurontin, chemical analog of GABA, a neurotransmitter that inhibits brain activity, believed to work by increasing the synthesis and synaptic accumulation of GABA between neurons. So more available, more activity, or less activity. I'm sorry. Used for seizures as an adjunct. Good Lord, but more commonly seen for neuropathic pain. Okay, Lamictal. So generalized or tonic-clonic seizures, also used for bipolar disorder. So this picture is pretty hard to look at, but that is Stevens-Johnson syndrome. So in this syndrome, your skin reacts pretty severely to the drug, and it like blisters all over. So definitely watch for skin reactions. Keppra, adjunct therapy for partial seizures with or without secondary generalization. No drug interactions. Yay, Keppra is a pretty decent one because it's got a pretty good safety profile, and then there's it's not on that metabolic highway. So Lyrica, structurally related to GABA but is not fully understood as a Schedule 5 adjunct therapy for partial seizures. Most common, though, is neuropathic pain and fibromyalgia. So, again, CNS-related adverse drug reactions. So what you would see if we were kind of talking about decreasing that activity of the brain, so you might see some drowsiness, some, somnolence, that sort of thing. So implications, assessment. Do you want details of that seizure disorder? What happens? When does it happen? What triggers it? Do all of your, what alleviates it? What makes it better? What makes it worse? When does it happen? How often does it happen? All of that stuff. Strong baseline neuro assessment. Health history, including current meds, including herbals, right? Any drug allergies, labs, liver functions, baseline vitals. Definitely maintain the airway during seizure activity, right? So if you see somebody who's having an active seizure, your priority is their safety and their airway. So if they fall to the floor, make sure things are away from them, right? They're not going to knock into a Dynamap or a blood pressure, the blood pressure machine or an isolation cart. Like you can move that away that has wheels. You're going to watch their airway. Are their clothes constricting around their airway? Then you can, scissors, you should have some scissors in your pocket. Always. I always had scissors in my pocket because I never knew when I needed them. That sort of thing for me. So, oral drugs take regularly at the same time each day. Take with meals and increase fluid. Do not crush, chew, or open extended release forms. If a patient is NPO, we need to talk to the doctor and say, hey, they're NPO, but they're on thus and so medication. So they may prescribe it IV if they can't take it PO. So IV forms given slowly. Usually they're in a bag of like 100 ml bag, and you give it over the pump over like an hour or a half hour, so it's pretty slow. And when we say given slowly, we mean not a push. So an IV push is like, you push it in quickly. If we talk about given slowly, usually it's like half hour or an hour infusion. Vitals during administration, avoid extravasation of fluids, so watch that IV site. Remember how we tell when an IV site is good? We have blood return, it can easily flush, and we have good blood return. And the patient's not complaining of any pain. Sometimes it's painful, they may have good blood return, but if they're continually complaining of pain, guess what? Just start another IV. It's much safer to just start another one and make sure you have a good patent IV than it is to go through a hinky one. Use with normal saline and a filter per package insert. If you don't know, ask the pharmacist because they can let you know. So nursing implications, so education. Teach patients to keep a journal. Like, are their seizures getting better? Do they have triggers? Did they notice that it occurs more at this, a certain time of day? All of those things, adverse effects. So they need to wear a medic ID. They need to wear a medical alert bracelet or something to alert emergency personnel that they have this condition, right? Because they shouldn't be discontinued abruptly. Follow driving recommendations. Sometimes if you have a seizure, you don't get to drive for a little while. Because how scary would it be if you were on the freeway and you had a seizure and you crashed? That's just not about you at that point, right? You're putting other lives at risk. So those driving recommendations are pretty strict, but for a reason, because you're, in charge of a huge car that can take out freaking houses. People run into houses and plow through stuff, right? So therapy is long-term and possibly lifelong. Not a cure, but we can definitely maintain control of those seizures, right? Safe-proof their homes. So what does that mean? Not a lot of clutter on the floor. If they fall, maybe they should get, if they have really hard floors, get some rugs or something, those sorts of things. Caution with activities requiring alertness. Again, not just driving. Are you banking? Are you signing a contract? Like, those things need you to be alert. And if you're on medication, this is how people sometimes get taken advantage of. Fall risks due to CNS depression, right? And potential for ataxia and drop attacks. So sometimes seizures, people kind of crumple and fall down and start seizing. So definitely they're a fall risk. Many anti-epileptics have tetragenic effects. So what does that mean? we need to caution against pregnancy, or we need to have a plan if the patient gets pregnant, right? Therapeutic effects. So we want to see decreased or absent seizure activity with a good quality of life and not a lot of adverse effects. So watch for adverse effects. So mental status changes, mood changes, suicidal ideation, right? We're going to ask them. Eye problems, visual disorders, definitely the skin reactions. We want to watch out for Stevens-Johnson syndrome. Vitals and respiratory. We want, respiratory status, vitals, CBC. We want to see if there's any blood, kind of aplastic anemia, agranulocytosis. So any kind of bone marrow involvement. So they may get anemic. They may have decreased white count. So they may be neutropenic. Sore throat and fever, blood dyscrasias may occur. So that basically means, their CBC could get funky because of the drug. So their blood count, their white count might be low, their red count might be low. So if they have a fever, they need to be aware of, avoiding people when you're sick, or don't go near sick people, and washing your hands, and all the things we're doing now in COVID land. But definitely they may be immunocompromised. Do not stop abruptly. Potential for rebound seizure activity. So think about it. Excuse me. We are depressing all of the seizure activity. So we're kind of depressing the brain's ability to fire. And when we lift that, guess what? It's super trigger happy. So you can go into maybe status epilepticus. So you do not want to just stop abruptly. So same kind of concept that we don't want to stop some hypertensives abruptly, because we could have a hypertensive crisis, right? Same idea. And then monitor for serum therapeutic levels on those drugs that need labs. We want to make sure they're not toxic and they're not below therapy, right? Okay, again, reach out to me with questions, guys.